So next up is the research fellow, Dr. Natour from the Henry Ford system. Again, on the theme of appropriateness, a little more in a specific way, probably a little less controversial than atherectomy. So go ahead.
Thank you, Dr. Hankey. All right, trying to.
I think you just have to click on the slide there and then you should be able to go, or the screen.
Yeah.
And you may want to go into presenter mode.
I'm trying to do that. Trying to click the presenter mode.
Let me get this back into presenter mode.
Okay, sure. Okay.
All right, here we go. Now I'll give you remote control.
Thanks, Pam.
Okay, thank you. Good afternoon, ladies and gentlemen. I'd like to thank the organizing committee for giving us the opportunity to present our work entitled Utilization of Pre-op Vein Mapping in Patients Undergoing Infra-Inguinal Bypass. I have no disclosures. So autologous vein has been shown to have the best patency rate when compared to other conduits for infra-inguinal bypass. Preoperative vein mapping with duplex ultrasound has become the standard for determining the presence and suitability of autologous vein as a bypass conduit. In addition, pre-op vein mapping has been shown to reduce unnecessary surgical exploration and postoperative surgical site infection in multiple studies. So the objective of our study was using a real-world registry to determine first the real-world utilization rate of pre-op vein mapping prior to bypass, and second, to determine whether pre-op vein mapping is associated with increased use of vein conduits. To do that, we used a large statewide quality improvement database. We queried all infra-inguinal bypasses between 2012 and 2020. Preoperative and intraoperative variables were analyzed, and postoperative outcomes were correlated with pre-op vein mapping using univariate analysis. So a total of 7,500 patients underwent infra-inguinal bypasses during the study period. After excluding trauma patients, patients presenting with acute limb ischemia, or patients who had previous infra-inguinal bypass, we ended up with around 5,500 patients. The average age was 67 years. Most of our cohort were male with 69% and white with 81%. Most of the patients did not undergo pre-op vein mapping prior to their infra-inguinal bypass with 55%. This table illustrates the baseline characteristics and some of the comorbidities of our cohort, comparing no pre-op vein mapping versus pre-op vein mapping. As we can see, patients who had pre-op vein mapping were more likely to be white, had commercial insurance, were slightly more obese, and had a history of diabetes. On the other hand, patients who did not have pre-op vein mapping were more likely to be current smokers and have a history of COPD. Patients who had pre-op vein mapping were more likely to present with lower ABIs and more advanced PAD with rest pain and tissue loss. On the other hand, patients who did not have pre-op vein mapping were more likely to present with claudication. Around 70% of patients who underwent pre-op vein mapping had a venous conduit for their infra-inguinal bypass, versus only 28% of patients who did not undergo pre-op vein mapping had a venous conduit for their infra-inguinal bypass, and this was statistically significant. When looking specifically at patients who had a vein conduit for their infra-inguinal bypass, we compared intraoperative variables, and as we can see, patients who did not have pre-op vein mapping had a higher estimated blood loss with 323 milliliters versus 291 for the pre-op vein mapping. Patients who underwent pre-op vein mapping were more likely to receive post-reconstruction imaging, and these imaging were more likely to be reported as normal. To note, there was no significant difference when looking at procedure length. When looking at postoperative outcomes, patients who did not have pre-op vein mapping trended to have a slightly higher length of stay, as well as 30-day transfusion, There was no significant difference when looking at other outcomes such as 30-day amputation, readmission, death, need to return to OR for infection, graft revision, and there was no significant difference between the two groups when looking at 30-day and 1-year patency. 46% of the overall infra-inguinal bypass patients in the BMC squared database used a vein conduit versus 67% in the VQI. When preoperative vein mapping was performed, these percentages increased to 69% for the BMC squared and to 74% to the VQI. However, only 45% of patients in the BMC squared had a pre-op vein mapping versus 68% in the VQI. As a summary, in the study, most patients did not undergo preoperative vein mapping before their infra-inguinal bypass. Patients who underwent preoperative vein mapping are more than twice as likely to have a venous conduit used for their bypass. In patients who underwent vein bypass, post-reconstruction imaging to establish technical adequacy was performed more frequently in patients who underwent preoperative vein mapping and was more likely to be reported as normal. In patients undergoing infra-inguinal bypass, preoperative vein mapping resulted in less blood loss and trended to have reduced length of stay and 30-day transfusion rates. Preoperative vein mapping did not result in a reduced rate of surgical site infection or other postoperative complications. To conclude, when compared to national benchmarks, surgeons performing infra-inguinal bypass in the BMC squared utilized both preoperative vein mapping and autologous vein conduits at a lower rate for infra-inguinal bypass. Preoperative vein mapping may be a marker for physicians committed to best practices for infra-inguinal bypass. Thank you, and happy to take any questions.
Thank you, Abdul. That was great and very clearly presented. I'll open up for discussion points or questions.
Yeah.
I guess I'd put a little out to the group. I mean, is it, or if anyone has a conflicting opinion whether to use prosthetic first, I think it's not surprising at 1 year probably not seeing a difference in patency between prosthetic and vein graft usage. But that seems to, in the literature, diverge at about year 3. And I think it is pretty well established in the literature that patients who include a prosthetic bypass in the infra-inguinal location tend to present more often with critical limb threatening ischemia versus those who have a vein bypass that re-occludes. So I don't know, Loie, if you have any comments as well, or Alex, or anyone on the call, Joshua.
Yeah.
Peter, oh, go ahead, Loie.
Oh, no. So I guess the main reason we were looking at this is that the question we're looking at for markers that we can include in best practices. And we've done a great job at the abstract at how we did with the mission quality initiative of using statins, aspirins, and other markers. And really the question that Dr. Shepard had asked me, and this is kind of why we undertook the study, is should we be including vein mapping as a quality indicator? Because I think the data shows that if you don't look for vein, you probably don't use it. But if you do look for vein, you use it about 60 to 70% of the time. And you should at least look for vein. I think that I don't think lose anything by doing a duplex ultrasound looking for vein. And what are I guess the question I have for the group is, what are the barriers? Why aren't we looking for vein? Why isn't every patient having an preoperative vein mapping to look for vein conduits before bypass?
Yeah, good question. Alex?
Yeah, I was going to say the same thing. And earlier in the presentation today, Carrie Basella talked about registry-specific quality improvement initiatives. And I personally think that this would be a great one for the national VQI as a quality metric. I don't know if Jens is still on, or Carrie.
I am. I like that idea. I think that's a great idea. We're always looking for new national quality initiatives. So happy to take that to the group.
Yeah, and I think the payoff is not always immediate. You noted the SSI rate was similar, but an SSI rate with a vein graft is, you know, with rare exception, not a big problem. You know, a SSI that occurs in the setting of a prosthetic, especially if it's not treated aggressively early, can lead to that graft getting infected, and then you have a real problem and have to remove it and then do the vein graft that was probably sitting there anyway.
I'd be interested in what other members of the BMC squared think. Maybe, I don't think anybody's going to publicly stand up and say they don't use vein, but maybe somebody could tell us why they aren't fans of preoperative vein mapping. What are the barriers, as Loie asked? One barrier we thought of is perhaps, you know, if you don't control your own vascular lab, you're at the mercy of a radiologist or a cardiologist who's running the lab. They may not put a priority on this. And it's critical for those of us doing preoperative vein mapping that you get a good vein mapping done. I mean, if the tech draws a line sort of all over the place and doesn't adequately mark branches and things, then it can really lead you astray and lead to big problems at the time of surgery in terms of misplaced incisions or undermining, which is the whole purpose of having an accurate pre-op vein mapping. So if you're doing poor preoperative mapping, I can see why that would be a impediment to utilizing vein mapping. But again, I think this is a good reason why vascular surgeons should be in charge of their own vascular labs.
Yeah, I agree. I think Matt Corrier mentioned that a CTA does often show a nice vein or presence of a vein or lack of a vein. And I think the group from Virginia published, UVA published this a couple of years ago. Obviously, you still probably want to use ultrasound and wouldn't get a CTA just for a vein mapping, but it's a useful piece of information that you can often find there as well. I totally agree. And then, but yeah, so I think that your idea to have this as a national quality measure is a great one.